So this is how you need to question everything. So this is severe hyperkalemia, so make sure we highlighted that. Okay, and we have chronic kidney disease. Okay, so now we need to know what we give in severe hyperkalemia. Do we need to give calcium gluconate? Just question yourself. In the hard one also we discussed that. So A, yes, okay, because it's gonna stabilize the membrane. So A is correct. What about B, IV insulin with dextrose? We just did. We just did in the other question. Yes, because it's gonna help to reduce the potassium, and dextrose because to prevent the hypoglycemia. So B is correct. Alrighty. What about C, sodium polycistrate sulfonate? We know this is potassium binding resins. It helps to excrete potassium with stool. Okay, so if we know mode of action, so this is yes. Okay, and that's why we need to know mode of action. That's why we need to know like how does medication work. And what about loop diuretic? If residual renal function, what about loop diuretic? D. Yes, okay, because we know loop diuretic are the big one when they because they can help to excrete potassium and fluid. You don't wanna give the spironolactone because those are potassium sparing diuretic, but loop diuretic really helpful. Okay, but as long as there is no hypotension, make sure we have enough fluid balance in body. What about lactated ringer bolus? What about E, guys? What about E? Yeah, we don't wanna give that. No. Okay, so E is big no. Because what happened? Because it's lactate ringer, it will metabolize into bicarbonate. Okay, and sometimes the lactate in the body can cause hyperkalemia. Okay, so we already having patient with hyperkalemia, so this is gonna be very poor choice. We need to give what we can give to this patient if we need. Thank you guys for following what we need to give this patient. Which solution we can give? Normal saline. Yes, thank you, triple service. Normal saline. Okay. What about ECG monitoring? Do we need ECG monitoring for hyperkalemia patient? Yes. Okay, just to make sure whether patient going with arrhythmias or not. Nice one, guys. So this is the reason, even though these questions are bit simple, you can actually gain lot of knowledge from this one and you can implement in the other questions. Okay, so never think that a question is simple. Always question the option. Okay, a patient with peritoneal dialysis reports cloudy, effluent, and abdominal pain. Which actions are appropriate? Select all that apply. So, what is going on when we know patient is with PD, patient is having dialysis, and it's cloudy? What's going on over there? So, this is how I question everything. We need to know infection. Yes, okay, so we are having peritonitis. This is how you need to question everything. Okay, so it is the infection of peritoneal cavity and it can cause serious complications. So now we need to know what's going on. Okay, so to know, is it best to send effluent for culture and sensitivity? Do we need to find out the infected organism? Yes. Okay, and what about keep the patient supine and notify the provider? What about B, guys? is supine. So this is the thing, like even notifying the provider is good, okay, but supine is not gonna make any difference. Okay, so B is incorrect. Alrighty, so we need to immediately notify the provider, but supine is not gonna helpful. So B is no. Warm dial state with microwave before next exchange. C. So with microwave, C, no, yeah, not safe because it can cause the hotspot. Yeah, and that can cause damage the perineum. So definitely not C. Okay. What about D, guys? Use aseptic T techniques for connection. Um, Actually, I will say this is incorrect because for the connection, um, this is correct. Yeah, this we can say safety always first. Okay, because it's only the preventative measure. It's gonna prevent the further infection. It's not gonna reactivate, suspected. Yeah, yeah, but it's clean. We don't need to do that. Yeah, it's not gonna change anything with the if we will. I know for safety good, but does it gonna affect anything with infection here? That's the question. Actually, if we will stay in NCLEX context of question, is it gonna affect anything with infection? We already have infection. Okay, yeah, not going to matter. Yes. Okay, so we can actually cross it over and expect IV antibiotics as prescribed. What about E, guys? E, yes, yes, definitely we need to. Even though we have sent for the culture and sensitivity, it's gonna take some time, so we can have some broad spectrum antibiotics administering to the patient. Okay, increase dwell time to promote ultrafiltration. What's gonna happen with F? If no, because then what's going to happen? Then it's gonna increase the infection by allowing bacteria to stay there for a long time, okay, in the peritoneum. So no, so only A and E. Okay, thank you guys for sharing, really appreciate. Please do subscribe YouTube also. This video and all the past videos are getting posted on YouTube, so make sure um, you subscribe over there too and share with your friends. So the nurse educate a patient starting furosemide for fluid overload. Which teaching are correct? Select all that apply. 13. What about 13, guys? So we know it is potent medication. It is potent loop diuretic. YouTube handle is same triple. It is Nursingi. If you will just search Nursingi, you will find it. And same, this is the logo. Same logo is there. A, yes, because rise slowly to prevent dizziness, because it can cause orthostatic hypotension. Okay, so A is good. What about B, guys? Report muscle cramp or weakness. Does furosemide have that? Yes. Why patient can have muscle cramp and weakness in furosemide? Anyone? Hypokalemia. Yes. Thank you, Triple. Thank you for subscribing. Yes, hypokalemia. Okay, not potassium overload. There is less potassium now because uh, they don't, we lost too much potassium with loop diuretic. Okay, limit potassium rich food. What about C? Does patient need to have potassium rich food or limit? C, no. Yes, we need to encourage, because this one can cause hypokalemia. So we need to actually make sure like they having consistent level. Okay, consistent level. We don't want to increase or decrease right now. We need to check before increasing. Expect increased urination. D, that's the desired effect. That's what we want to see in patient. Yeah, or good. D is correct. And what about E? Avoid talking at bedtime. Oh, sorry, not talking, taking. I don't want to shut up here. Okay, avoid taking at bedtime is correct actually. Okay, so yeah, so they don't need to get up at night. Yeah, yeah, it will disturb the sleep. Watch for ototoxicity with high IV dose. Yes, this is one of the main side effect that we see in furosemide, especially if it is given IV. Okay, so we wanna watch that one. Definitely correct. Alrighty, 7 questions left for this session. Okay, guys, a patient with AKI, oligouric phase, again, there is not enough urine in 24 hours. What's happening? Which are appropriate? Which order is appropriate, guys? Daily weight. Always. Adriana going back. Here we go. Please let me know as soon as possible. Okay, 14. Daily weight always. Okay, if we are giving diuretics to patient, and if somebody is having edema, generalized edema also, especially in kidney disease, daily weight on same time is very important. Alrighty, next one, fluid restriction to prevent the odor. Fluid restriction as per order to prevent the edema. Yes, fluid retention. Okay, because if patient is taking too much fluid, and then we need to make sure it will not cause the fluid retention, so that's why we want to restrict it. High protein diet to build muscle. Oh my god, do we worry about building muscle at the moment? No. Okay, so we don't. What will happen if there is a high protein intake? What will happen to body? Kidney can't get rid of it. Nice. Okay, and it will create the nitrogenous waste, BUN, that can damage kidneys. Okay, so don't do that. Avoid nephrotoxic drugs. D, patient already having AKI, already injury to kidney, and then yeah, we need to avoid it. Yes, ammonium. Monitor potassium closely, because we know what can happen in AKI. Kidney function is not going normal. What can happen? Hypo or hyper? Yes, we need to watch for it. What can happen? Hyper. Yes, Vinny. Thank you. Especially in oligouric phase, because there is not enough excretion going on. So that's why it can be hyper. Renal dose medication adjustment. What about F, guys? Thank you guys for following and double tapping. Filtration is off. Yes, thank you. What about F? Do we need to adjust the dose? Yes, always. That's why we need to check the throw level. That's why we need to check whether it's not accumulating and causing the toxicity. So F is yes. Thank you guys. Six more question, and we need six more subscriber right now. So please search Narsingi on YouTube. I will post this video over there. And if you are just joining us, we already done pharma prioritization med search. This week we are just doing topic wise. So yesterday we done cardiovascular, that will be uploaded. Today we done maternal, that will be uploaded on YouTube, and now we are doing kidney, that will be uploaded on YouTube also. So please search Narsingi and subscribe. Okay, the nurse receive report on 4 renal patient which require priority assessment. Let's do, guys. And this is SATA. So make sure we select multiple. We don't have to select one. A, yes. Please go through all the options first. So then we can select. A, yes, bleeding, but it is expected bleeding. Okay, when we have tub, okay, it's just post tub. Okay, and it's bright red urine and clots is still not healed. Okay, so this is expected sign. This is expected sign. What we need, TURP is transurethral resection of prostate. Okay, when there is a resection of prostate gland, so that's why. Okay, and what we need in this condition, we need continuous bladder irrigation just to prevent the clot accumulation over there. So okay, so this is not the priority right now. Peritoneal dialysis patient with rebound tenderness. What about B, guys? When we have rebound tenderness, what's happening? C and D. Thank you, dear diary. Really appreciate. B and C, yes. Okay. Rebound tenderness. What it is sign of? It is sign of peritonitis. Thank you, yo. Okay, so this is sign of peritonitis and which can lead to sepsis. So this is medical emergency. So we need to see B. What about C? Hemodialysis patient with blood pressure 86/50 and dizziness. Patient is very hypotensive. Yes. Okay, circulation. We're gonna do C also. D, CKD patient asking for snack. Is snack priority? Is snack a priority? No. Okay, sorry, I will come back to you later, or I will delegate this task to someone else. Okay, UTI patient with dysuria rating 610. What about E, guys? You know UTI isn't it expected? Yes. Okay, so UTI patient dysuria is expected. Okay, so we don't want to worry about that also. And what about nephrotic syndrome patient with 1 plus edema? We know nephrotic syndrome. What about F? Expected as well. Okay, so thank you. We can have edema over there. So that's gonna stay there for a bit long time until we will sort out the nephrotic syndrome. So we don't need to prioritize. So only B and C is prioritized. Okay. Let's move to question number 16. So teaching for calcium acetate, a phosphate. What is post-TURP? Post-TURP is, so TURP is transurethral resection of prostate gland when they remove it. So post-TURP, like patient just have the surgery and came back. Okay. So we have calcium acetate now, a phosphate binder. We just done that. Which statement indicate understanding? So we are just teaching the patient. Let's do that. And we just discussed that before, like we give it to the patient, yes, mostly in BHP, definitely, because it pressurizes the urethra and doesn't let the urine pass through. So that's why they resection it, they remove part of it. Yes, I will take it with meal. Correct, because phosphate binder we always take with meal, just to prevent the hyperphosphatemia. It lower my phosphate. What about? Oh, I was thinking you were saying benign prostate hypertrophy. B, yes. Okay. They understand why we are giving this medication to reduce the phosphate level in body. What about C? It might cause constipation. Can it cause constipation? This is calcium, guys. This is calcium. C, yes. Yes, okay. So calcium, it is most common side effect of calcium-based binder. Okay, yes, nice. And I will take it with iron, so they work together. Can they take together? What will happen if we are taking phosphate binder like Sevlemar and iron together? No, because they will compete with each other. They work through same transporter. So if you are giving calcium and iron, they gonna fight. Okay, I wanna get first, I wanna get first. And nobody is gonna get first over there. Okay, they can't. I won't take it if I skip a meal. This is correct. E correct or no? No, it is correct actually. Okay, E is correct. So medication purpose is to bind with phosphate from the meal. That's why you take it with meal. Okay, there is no other phosphate in body on that time. So when digestion happen, yes, Winnie. So you wanna make sure like a patient is taking the meal, then we are giving the phosphate binder. They can't take it, like they can't have meal some other time and these medications some other time. Okay, so they need to take it with meal, because then it will take out the phosphate that's in the meal and excrete it with stool. Okay, I will chew it thoroughly if it is chewable. What about F? Actually, this is correct. Okay, because why it's correct? This is the understanding if it is chewable. Okay, so that's why. Yeah. Okay, if it is not, then I will take it normally. That's what patient is saying. Yeah. So another thing is that when we chew the calcium or phosphate binder, calcium acetate, then it will increase the binding. Okay, it allow better contact binding with the food. So that's why it's okay to chew it if it is chewable. Okay, we have 4 questions left for today, and then we're gonna have a bit of rest. The nurse evaluate a patient with glomerulonephritis for complication, which are expected risk. Select all that apply. Increase surface area. Okay, so I will say like otherwise, because it's gonna take time to break down first and then bind to the phosphate and then it's gonna excrete. If it is already broken, then it gonna make it quick to act. Thank you guys for following and double tapping. Really appreciate. Okay, glomerulonephritis. We have inflammatory disease right now. And we know in glomerulonephritis there will be lot of fluid overload, hypertension. Yeah, so everything is complicated. Okay, hypertensive encephalopathy. Likewise, I just talked, there will be hypertension. Can we see A in those patients? A, yes, yes, definitely you're gonna see. And severe hypertension, it can lead to neurological emergency. So we need to make sure, like, watch out for headache, for confusion, seizure, dizziness, lethargy. If patient is complaining about confusion, please make sure we check blood pressure and notify the provider immediately. Hyperkalemia. So this is glomerulonephritis. There is inflammation going on in the kidney. Kidney can't perform its function properly. Is there chances of hyperkalemia? Yes, yes. Okay, because make sure kidneys functions are affected. Okay, so hyperkalemia is evident. Hypovolemia from polyuria, we just talk about that. What we gonna have, hypovolemia or hypervolemia? Do we gonna have polyuria or oligouria? What we gonna have, guys? Yeah, it's wrong. Hyper. Okay, we gonna have fluid retention due to oligouria. Likewise, we discussed kidney is not performing function properly. Okay, so oligouria. Pulmonary edema, we just give the rationale for that one also. There is a fluid retention, there is oligouria, body is not excreting fluid outside, so you will see edema over there. Yeah, cool. Okay, now we're gonna see metabolic acidosis or other thing. What about E? Yes, okay, metabolic acidosis, because kidney now can't excrete acid and reabsorb bicarbonate. That's gonna lead to metabolic acidosis. Nephrolithiasis as primary cause. Is kidney stone our primary cause? What about F, guys? No. Okay, F is not correct. F is not correct. Okay. Why we have glomerulonephritis is mostly immune response. Okay, it's not kidney stone. Okay, so please, we don't need to worry about that one. That may be secondary. Yes, it can be secondary. Okay, it's not primary cause. Primary cause is immune response. Yeah. Okay, three more question. Thank you. And I need 3 more subscriber on YouTube to make it 180. If you haven't subscribed, please go and search Nursingi, and really appreciate all of you guys. Okay, the nurse care for a patient after extracorporeal shock wave lithotripsy. Which instruction are appropriate? Select all that apply. Question number 18. We have 15 question in this one. We will come tomorrow live same time, 10 p.m. EST, 10 p.m. New York time, to do rest of the questions. Thank you guys who just went. Please always comment when you come back and subscribe. Just let me know it's good. Okay. So why we do ESWL? Just to break down the stones. Okay, but with the help of shock waves. So can we expect hematuria for 24 to 48 hours? When there is a stone going through the ureter? Yes, definitely. Okay, because they can cause bit of injury to the ureter. So that's why increase fluid intake. Do we need to increase fluid intake? We have done that in last question, one of the last question today. Yes, so you will have more fluid to flush it out. Alrighty. Avoid NSAIDs for 1 to 2 weeks unless approved. We done that one. Do we need to avoid the NSAIDs or do we need to take the NSAIDs? C, yes. C is incorrect, guys. Okay. C is incorrect. Make sure this is not for the kidney injury. Okay, this is for kidney stone. There is different things. Okay, this is not for the kidney injury. There is no evidence of kidney injury in the question, so we don't want to avoid it. When you NSAID is the first choice for pain and inflammation after the stone. Okay, so we're gonna take it. This is incorrect. If there is a kidney injury, then definitely, if it is evident, like patient is having AKI, patient is having CKD, then we will see. Not in this one yet. Strain urine for fragment D. What about D? Is D gonna help? Yes, so we want to know what kind of stone composition is, and we can work around that. Thank you guys. One more to make it 180 over there. Really appreciate. Report fever or severe pain. E. E, yes, because this can be sign of infection, inflammation. So it can be also sign of like a stone is blocking the way. Yeah, obstructed into urine. So ureter. So E is yes. Bed rest strictly for 72 hours. We done one of the question before. F, yes, no. No, because ambulation help with moving stone. You don't want bed rest. Okay. Alrighty. Two more question and then we're good. So a patient with CKD has pruritus. Which intervention can help? Select all that apply. Question number 19. So pruritus, itching. Thank you guys for following. It's itching and it is common symptom in CKD. We know. So use emollient cream. A, yes, moisturizer gonna help. Definitely. Thank you, super. What about keeping nail shorts? What about B, guys? What will happen? Yes, because it will reduce the risk of injury. Okay, if there is some scratch. What about C? Hot shower twice daily. You wanna do hot shower or you wanna do lukewarm? No, okay, we don't do hot shower, we do lukewarm. What about phosphate control per orders? D. Yeah, just D. Because hyperphosphatemia is one of the major cause of pruritus. So that's why. So make sure we remember P and P. Okay. So we wanna control it. We don't wanna give it to patient. Okay, this one is correct. Cool room, loose cotton clothing. Is it gonna help? Is cotton clothing is not irritating, so that's why it will definitely help. And what about antihistamine as prescribed? If yes, yes, that's definitely gonna help from the itching. Nice, guys, we are doing so good. Okay, let's see. This is the last question for the evening, and we will see after that. So, the nurse teach a patient with neurogenic bladder using intermittent catheterization, which are correct steps. Select all that apply. Question number 20. Perform hand hygiene before the procedure. A. Safety. Infection prevention control. Always yes. Always yes. Yeah. Using the clean technique at home if appropriate. Is it if patient is self catheterization and they can do the clean technique? Yeah. Yeah, they don't need to be sterile, they need to use the clean techniques. Yes, at home. Insert catheter using sterile glove at home. uh See, yes or no? Not sterile at home. Yes, yes. Yeah, still. It is recommended like at home they can use the clean technique. It is enough. It is typically sufficient and safe. Yeah, yeah. So see, no, clean is good. Yes, thank you, Nico. Advanced catheter until urine flow, then a bit more. What we are checking here? D, yes. Yes, D is definitely yes, because this is telling us whether catheter in the bladder. And what about E? Drain completely, then remove slowly. Yes, okay, because then it's just make sure like bladder is completely empty.